All right, good morning, everyone, and welcome again to another installment of the NB Heart Center CV Weekly Rounds. I just want to take this opportunity to thank our guest speaker for this morning, Dr. Michel D'Astous, who's a cardiologist at the Georges Dumont Hospital in Moncton. He joined the practice there in 1993 after having completed his training at the Université de Laval. And we consider Michel, I think, one of our really esteemed colleagues in this province. He has great clinical expertise and has collaborated beautifully with the New Brunswick Heart Centre over the years, has really been an active member of the Symposium Planning Committee with Dr. David Buick. And I thought it would be an opportunity for us to engage him and his partners and to get a sense for how the Ischemia trial, which was published earlier this year, has impacted his practice. I think we've all kind of spoken about the Ischemia trial and spoke theoretically to some extent about how it's changed our practice here at the Heart Center. But I think it would be nice to kind of get it from a different perspective, where obviously the threshold for cardiac cath or PCI/CABG is probably a whole lot different than it is here. So without further ado, I will pass it over to Dr. D'Astous. Thank you so much.
All right. Well, good morning, everybody. And thank you, Ansar, for that very nice introduction. And also thank you for inviting me to talk about how ischemia has or hasn't changed my practice. So when I looked at the title, I actually thought of Dr. Let me see here. I can't advance my slides here. There we go. I thought of Dr. Lyle Higginson, who once said, when they start talking about your practice, it means you've been here for a long while. And by looking at this slide, I'd actually been here a long time because I can remember all those phases of life. And also when I graduated, this was the last time my hockey team won the Stanley Cup. So it has been a while I've been here. So let's go back to 1993, 1994, when I arrived, end of 93, basically. At that time, when we had patients, we would refer them for outpatient cardiac catheterization. And sometimes they would have to wait up to 12 months and even more in certain cases. So actually, we had to send a lot of patients out of province for coronary interventions. And of course, then stents were not, especially drug-eluting stents, were unheard of or very rarely used. So we had angioplasty and a high rate of restenosis. So patients would actually go back a second and sometimes a third time after cardiac catheterization and revascularization. Even the inpatient cardiac catheterization, patients wait up to 3 weeks in the hospital. We'd have patients having recurrent MIs, pulmonary edema, intubation, cardiac arrest. These were things that are happening on a fairly regular basis. So things have changed a lot. So if you look back in 93, 94, due to the long wait, medical therapy at that time was actually predominant. So a lot of people were treated medically. They came in with an event, or they were seen as an outpatient, had a stress test, looked good, we sent them home on medication. However, there were a lot of crossover over the years. Patients have crossed over to the intervention side, but I still see on a regular basis patients that have been following for 15 to 20 years or more and are still doing quite well and have never had an angiogram and are still doing clinically well. So in fact, when I looked at everything, what has really changed since I've been here is early revascularization. So in fact, especially in the STEMI with the new STEMI protocol, the Heart Center, and all the outpatients rapid cardiac catheterization, this has changed my practice. However, let's look at medical therapy versus revascularization. So the first big trial was the Courage trial back in 2007, presented by Bill Bowden. And I was actually at that session. It was kind of interesting. So this trial was the first larger trial involving optimal medical therapy versus PCI and optimal medical therapy. Now, it took over 35,000 patients to get 2,200 patients, or 6% of the population. And one of the reasons was that the anatomy was known prior to randomization. And Dr. Bowden did mention this, that a lot of cardiologists were quite uncomfortable treating patients medically once they saw their anatomy. So this was a big issue. And also in the trial, there was a 33% crossover rate. So in the end, after the 4.6-year follow-up, there's no difference in death and non-fatal MI, no statistical difference. Now, this was certainly reassuring in a sense. However, there was a lot of critiques of that trial. One of them was a selection bias. And also, if you look now at contemporary cardiology, I mean, drug-eluting stents were not used. FFR-guided PCIs were not used. And Courage was strictly a PCI trial, not a CABG trial. So it was revascularization, but done percutaneously. So this set the stage for the ischemia trial. So ischemia trial started actually in 2012, went up to early 2018, and then was presented at the American Heart Meeting in November 2019. So at that time, we didn't realize, but that was probably one of our last big meetings for a long while in a face-to-face situation. So the ischemia trial set out to do answer a question. In patients with stable, and I really insist on stable coronary disease with at least moderate ischemia, was there any benefit of cardiac catheterization and, if possible, revascularization versus medical therapy? At that time, it was uncertain if the revascularization, either by PCI or CABG, would be superior to optimal medical therapy. And we were also wondering, will revascularization decrease the risk of MI or death? So that was the premise of the ischemia trial. Now let's look at how they randomized patients. So they took patients over the age of 21, and those patients had to have significant ischemia. So that was defined as a nuclear stress test with over 10% of ischemia involving the left ventricle, which is significant. And stress echo, which showed that at least 3 segments had signs of ischemia, a positive stress test with significant SC segment depressions. There was also some CMR criteria, which we don't really use here in New Brunswick. So these were the sort of the way to pick up patients with significant ischemia. Then the patients went on to have a cardiac CT. And the reason they had a cardiac CT was twofold. First of all, to confirm that there was presence of significant ischemic heart disease, as we can see up here, and also to exclude left main disease. So this was very important. Patients with left main disease were excluded from the trial. And they also had other exclusion criteria. For example, severe heart failure, functional class 3 to 4, people that had a lot of angina despite medical therapy, ES below 30% as the STITCH trial, and acute coronary event within the last 2 months, as well as a few other criteria. So patients were seen by cardiology, did the stress test, form an echo, nuclear, or so forth, and then had a cardiac CT. 73% of the people had a cardiac CT, whereas the 20% that were left did not, due to 2 reasons. One, the anatomy was already known, or secondly, if their EGFR was below 60 and above 30. So below 30, they were not randomized. They were not involved in the trial. So once you confirmed everything, you did have coronary disease, significant coronary disease, and significant ischemia, you're randomized to the conservative group, which was medically treated, and to the invasive group. And there was also a possibility of crossover. So what were the endpoints? Initially, the endpoints were the same as in COURAGE, which was time to CV death or MI. But due to the low event rate and also the randomization that was a bit slow, they expanded the primary endpoint to a 5-point MACE, which was CV death, MI, hospitalization for unstable angina or for heart failure, and then resuscitate cardiac arrest. So this was the 5-point MACE. The secondary endpoints were time to CV death and all-cause death. So as I mentioned, the trial was somewhat changed during the protocol, but mostly to increase the recruitment and try to get more patients that have significant ischemia. So how did the study go? Well, first of all, they randomized 8,500 patients. Unfortunately, about 3,300 of them and above had to be excluded since they did not have any significant ischemia or obstructive coronary disease on the cardiac CT. And also there's about 400 people that had an unprotected left main, which were excluded from the trial. So once again, left main excluded. And then they would randomize them to invasive group and conservative medical therapy and follow for a median of 3.3 years and up to 99% of follow-up, which is really excellent. So it's a very well done study that was done and presented, as I mentioned, 2019. So as we often see in those big trials, the 2 groups were completely superimposable, about 23% of females, 40% of diabetics, and normal ejection fraction. So the 2 groups are totally superimposable, involving the conservative invasive group. And also, this is quite interesting, they had to have significant ischemia, and 54% of them were felt to have severe ischemia, 33% had moderate ischemia. So it was not a mildly abnormal stress test, but really significant ischemia documented. And this was borne out by the cardiac CT. So as you look here, almost 50% of the people, 45 to 47%, had 3-vessel disease. And additionally, 46 to 47% had proximal LAD lesion. So once again, this was significant ischemia with significant coronary disease. So how were the patients evolved? So first of all, in the invasive group, if you look on the left-hand side here, 96% of the patients eventually went on to have a cardiac catheterization. And out of those 96%, 80% had some form of revascularization. In the medical group, there were still 28% that went on to have a cardiac catheterization, and 23% had revascularization. When we look subsequently, we note that most people that had a revascularization in the non-invasive group and conservative group actually did not have a primary event. Only about 7 of the 23% had a primary event before being switched or crossed over to the invasive group. So fairly good follow-up, as I mentioned. Let's look a bit more in the invasive group now. So we said that 23% would get intervention in the medical group, but in the invasive group, 80% had a form of revascularization. The 20% that did not have revascularization, actually 2/3 of those, of the 20%, did not have significant coronary disease despite the cardiac CT. And 1/3, in fact, had too much coronary disease that they were unsuitable for any mode of revascularization. So once again, 80% had revascularization. Out of those 80%, 3/4 had an angioplasty with a good number of drug-eluting stents, as you can see down here. And on the surgical side, 26% had surgery, and a good percentage of those also had arterial grafts and lemur grafts. So, pretty good therapy in those patients. So once again, invasive, only 8% had revascularization, and 23% crossed over in the conservative group. This is the medication used over time, and it's somewhat, I must admit, surprised me. The beta blocker use and calcium channel blocker use did not really decrease significantly, possibly due to hypertension. Beta blockers maybe for other reasons, but certainly calcium channel blockers did not decrease, although the other anti-angiologist medication did decrease, probably mostly nitrates. And as you can expect, dual antiplatelet therapy was more common in the invasive group, which had angioplasty. So no significant difference, but in the end, the patients that had revascularization seemed to have less angina. So let's look at the data. So after a median of 3.3 years, and at 4 years, there's maybe a trend toward the invasive group being favorable, but no statistical difference when we look at the 5-point MACE of CV death, MI, hospitalization for unstable angina or heart failure, or resuscitate cardiac arrest. No statistically significant difference. So that's interesting. As well, when we look at CV death or MI, maybe a same trend, but no statistical difference once again at 4 years. If we add on stroke, no difference once again. And in CV death and total death, there's really no difference amongst the group. And what was surprising was actually the low event rate. The CV death, the total mortality was 6.5% at 4 years, which was felt to be low since these patients had very high risk at first. So in the end, when we look at all the data, the solid endpoints, there's no significant difference, although a trend. Now, a lot of people have said this study should be ongoing, and we're hoping that it will, because as for the STITCH trial, the data came a little further down the road after more years of follow-up. So hopefully this will maintain itself. Now, there's one subgroup of elements or endpoint that favorized the invasive group, the myocardial infarcts. So this was somewhat of a debate because the definition of myocardial infarct would influence which patients would have a heart attack and if there's any benefit. But in the end, it does suggest that the invasive group has more peri-procedural infarcts as expected, but probably less spontaneous infarcts in the long term. So maybe this subgroup of events is the only one that was really modified by the invasive group. And once again, this was up for debate. So what's about this ischemia trial? Well, first of all, it was an unblind trial. There was no sham procedures that was done way back in the 70s. Based on the exclusion criteria, the trial does not apply to patients, once again, that have unstable symptoms, low EF, left main stenosis, and highly symptomatic patients. Also, the completeness of the revascularization has not yet been assessed, nor has the type of revascularization. So that data is still not available at the present time. The curves of the primary endpoint do cross over at 2 years, and maybe there's a trend toward the invasive group at 4 years, although this is not statistically significant once again. We talked about the myocardial infarcts that seem to be decreased in the invasive group. And we also talked about the low all-cause mortality, despite these patients at high clinical risk. This was actually a good news. And one of the important effects here is that Independent of the underlying coronary disease, the severity or the severity of the ischemia, there does not seem to be a difference in the treatment effect. So in other words, severe ischemia, medically or invasively treated, has the same effect. And very low rates of procedure-related stroke and death. This was also very good. So ischemia is the largest trial of an invasive versus conservative strategy, which has really over a 3.3-year period, median 3.3 years, shown no solid endpoint difference. So what do I think of that? Now that was kind of interesting, and as Ansar mentioned, we are from a non-interventional center. Although I really consider the heart center being across the street from the Dumont Hospital, when I talk to patients, I really have no limitations when I do refer them to the heart center for a cardiac catheterization if I feel it is appropriate. But what do I think of the ischemia trial? Well, first of all, in stable patients, or what we tend to call chronic coronary syndromes now, medical therapy and revascularization are both safe and effective. PCI and surgery are great options for angina and ischemia. And as I mentioned, in the trial, there seemed to be less angina in the invasive group. But when I talk to patients, they have to go for the right reasons. A lot of patients would like to go for cardiac catheterization thinking that they may not have pills in the end. So this is not the right reason to go. So they still need risk factor modification and also optimal medical therapy. I explained to patients that when we go for cardiac catheterization, we revascularize the severe stenosis, but there are a lot more of those vulnerable plaques that are prone to rupture, unstable angina, and sudden death. And for that reason, they do need very aggressive optimal medical therapy. So in ischemia, once again, medical therapy versus revascularization, there's really no downside to either therapy. And I'm very comfortable either way. Often this will be related to patient preference when we sit down and talk the whole thing. Now, so ischemia has not really changed that much, but certainly helps me reassure the patients if they're not comfortable going for angioplasty. Cardiac CT is not just to rule out ischemic heart disease. In cardiac CT, I used to use that as a sort of test to rule out ischemic heart disease. Now I use it to maybe confirm more coronary disease or the extent of it. So that has changed my practice. Stress echoes also changed my practice, as patients with a stress echo, when we see a big chunk of myocardium that starts contracting on ischemia, I must admit I was quite tempted to send them for cardiac catheterization, and I still am. But I think if patients are uncomfortable, I would be fairly reassured that medical therapy is appropriate. But once again, what has really changed, I find, over the last few years is optimal medical therapy. And two of our gurus in cardiology, Elliot Antman and Eugene Braunwald, who did actually the editorial from the ischemia trial, both mentioned that in the end, there's no clinically meaningful differences at 4 years for this trial. However, it does underscore the benefit of disease-modifying pharmacotherapy. And I really think that over time, the optimal medical therapy is what's going to have to be changed. As we know, when we have an acute event, patients tend to recur. And as they get further and further from their acute myocardial infarction, the events decrease, but there's still a 3 to 5% risk of cardiac complications in the long term. So this is why patients will have to modify their habits, still get optimal medical therapy, and be followed for the long term. Now, I had more slides, and unfortunately, due to technical issues, I'm a bit delayed here. So I'll try to just give you briefly my point here. This is the typical optimal medical therapy: aspirin, plus or minus dual antiplatelet therapy, lipids, mostly with statins, ACE inhibitors. I personally do not give beta blockers in patients that have stable coronary disease and a normal ejection fraction with complete revascularization. I shouldn't say, so coronary disease that have been completely revascularized with normal EF, I do not give beta blockers. And as I said, unfortunately, due to time restraints, I will skip a few slides, but the guidelines for cholesterols are changing. So Canada, which will have new guidelines soon, will probably get closer to the European guidelines, where we'll aim an LDL below 1.4. And if they have recurrent events, even an LDL below 1. So this is what is coming up. We also have changes in thrombus formation. We used to give platelets. Now we're giving, because of the COMPASS trial, platelets in the form of aspirin, and low-dose rivaroxaban. And these drugs, these studies, the COMPASS trial has clearly showed clinical benefit with a higher risk of bleeding, albeit mostly nosebleeds and GI bleeds with no fatal or critical bleeding. Another element would be inflammation. So inflammation, as mentioned, has been known to be a factor for coronary disease and risk of cardiac events. Recently, the colchicine was studied in the LODOCO trial, which clearly showed that when we took stable patients and looked at a 4-point MACE, which was significant, there was a significant drop of the primary endpoint. All major endpoints were decreased, most of them, I should say, except for stroke and CV death. And this was also borne out as a post-MI study, which we actually participated in. So inflammation clearly has a role to play as well. And in the patients with acute coronary event, the earlier you give the colchicine, the more bang you get for your buck. So once again, inflammation. So we're talking about lipids, thrombosis, inflammation, and now lipids in a different form, because since the first trial with the 4S study, there's been no new drug added on to statins that decrease cardiovascular mortality, except the recent REDUCE-IT trial, where we give IPE, which is basically a purified form of a EPA, and the EPA is quote unquote the good omega-3. And when we tried this study in patients with vascular disease or with diabetes and a risk factor who are already on a statin, we showed clinical benefit and decrease of all endpoints, including CV death. So ischemia has changed my practice somewhat, in the sense I'm more reassured. But what I really think is going to change in the long term is the optimal medical therapy. And this will be our job to try to find out who can benefit and which one of the drugs should we give. So once again, ischemia was medication versus revascularization. Some people have even said that this could be the death of PCI, which I really don't think. And I'd like to go back in the trial, how it's entitled initial invasive. And I really insist on initial invasive because the two treatments are not exclusive. We are certainly reassured that medical therapy is not bad, but I would be very aggressive in young people that have very few medications. So we tend to be a bit more aggressive when we see more ischemia, and that probably will not change my attitude. So some things don't change, but what has definitely changed is that the great collaboration we're getting with the Brunswick Heart Center, this has truly changed my practice, as now we have much more contact, discussions, texts, and we can talk about patients much more. So I would end here. Sorry for the delay and sorry for being a little fast at the last slides, but certainly if there's any question, it'd be my pleasure to discuss it.
Michel, thanks so much. That was fantastic. I'm just going to stop your screen share.
Perfect. Thank you.
Jean-François, JF, why don't you take it away?
Yeah, thank you, Michel. That was a great talk. And I just wonder if your thoughts, what I see at the change in my mind or my practice is, we do always have some patients that for a variety of reasons end up waiting for a long time for decisions we made many months ago on revascularization. And you see them in clinic or you see them when they come and they feel great. And they've become now these classic ischemia patients. There's several patients that have postponed and or said, maybe we've proven that this is the right therapy for you at this time, while 6 months ago, I thought revascularization was the best strategy. What are your thoughts around that? Am I wrong? These are difficult things, and I'm sure patients come to your office. Why am I getting this?
I agree. Well, thanks for the comment. But listen, I totally agree. And actually, there's a lot of patients that are quite scared to consider coronary intervention. So we get both types of patients. The ones that really want to go because their brother-in-law had a stent and feels great, actually sleeps better with his stent. So we get all those, those types of information or following surgery. But I agree. I think it reassures us that if patients do well, there's no urgency to consider. Now, I always tell them, my usual typical example I give patients is angina is like arthritis of the knee. Right? So it's predictable, you can treat it. A heart attack is what we try to prevent, but that's very unpredictable. So patients have to go for the right reason for revascularization. And they really think they're gonna, maybe not have a heart attack or not die or a stroke or what have you. They're sometimes convinced that they have to go there for that reason. But often, as you mentioned, by the time they get to see you, and if they don't have any, prognostic modifying anatomy, I think it's very reasonable to treat them medically. And as I said, I do still see a lot of patients that have never had a cardiac catheterization.
And do you in practice along the same line do re-stress them to see if their exercise capacity, they're really telling you the truth rather than say, well, I feel great, but they really do nothing?
Yeah, that's a good point. I mean, for angina, I actually rely a lot on their symptoms and I do re-stress them. I do that a lot for valvular disease mostly, but for coronary disease, I agree. I re-stress them. I make sure that they're stable. And sometimes it's not easy. You try to question them and you really can't get all the information. So stress testing is still a good option. I totally agree. But we have good medication. Unfortunately, some people get side effects. Some people, especially, when you get the young person that was not taking no pills and all of a sudden he comes up with 4 pills, it's those are the ones that tend to be more aggressive, uh, depending on the stress test, of course. But honestly, I mean, and this is truly the way I think about it. To me, the heart centers across the street from the Dumont. In other words, if I feel that they need a cardiac catheterization, if I'm uncomfortable, I will tell them. Most people are very comfortable. And I would say it's a minority that are actually scared to go for cardiac catheterization now. I mean, the people know somebody that has had a procedure and they do well. So I think good clinical follow-up is also important. But once again, I'm quick on the draw to refer them for cardiac catheterization.
Sharif, you want to ask your question?
Sure. Thank you, Michelle. That was excellent. So in the past, we've kind of considered proximal LAD as being prognostically significant. And anytime I saw anterior ischemia, I was like, okay, you definitively need to go because, this might be prognostically significant. Does this trial help us in any way of trying to sort through that? Is that still apply? And then my second one is just more about diabetics classically, and this might be more for the surgeons. Diabetics, multivessel coronary disease, if it was between PCI and CABG, we would tend to go with CABG because of previous data. Should we be, or should we be leaving them alone?
Well, thanks, Sharif. That's a very good question. So I think the trial is reassuring. I mean, it does say that, almost 50% had proximal LED lesion, and a lot of them also had other vessel disease. So in the sense that the trial does reassure, I must admit that, as you said, in my case, I'm not that reassured that much. So if I saw a significant ischemia involving the LED, I certainly would probably cath them to rule out left main first, or at least do a cardiac CT, but I haven't done that so much as of yet. But since I've been doing stress echo, I find that stress echo really is impressive when you see a big piece of myocardium that becomes akinetic. So the trial is certainly reassuring. I'm not sure yet if that's going to change my practice or not. And I think, at least we should rule out left main as they did in this trial. And for diabetics, I agree. I mean, diabetics are a whole kettle of fish. I think we should be very aggressive. But if they have signs of focal ischemic heart disease, there was a 40% diabetic population in this group. So that's certainly reassuring as well. But if you have any suspicion of, what I call prognostically modifying anatomy, I think they should be referred for cardiac catheterization.
I'm just going to ask one last question on behalf of Dr. Marr. When do you choose to send somebody for a cath versus just doing a simple straight up coronary CT?
Well, you know what? As I mentioned, the cardiac CT to me was initially mostly to rule out ischemic heart disease in patients that had inconclusive stress tests. I'm not certain as of yet how comfortable I am. I've been doing quite a few more, and we're trying to make a correlation with the cardiac catheterization. And so far, actually, our results have been pretty good. But my way of thinking is if my stress is abnormal, the patient is symptomatic, instead of doing 2 tests, I will send them for cardiac catheterization. I mean, there are 2 tests that involve, radiation and so forth. So if I'm suspecting that it will have revascularization, I go straight to cardiac cath. If I don't want to rule out something, then I'll go to cardiac CT.
That sounds very reasonable. Michel, that was a fantastic talk, and I think if we were having our annual symposium, this would be a great keynote lecture. So thank you so much for taking the time to prepare this and to present to us. I think we all greatly benefited. Wish we almost had more time. On that note, I would like to thank everyone for participating. Next week, Sue Morris from the Heart Center will be talking about resuscitation guidelines and how those have changed. Once again, Michel, thank you so much, and have a great day, everyone.
Thanks, Ansar. Thanks, everybody.